Okay, well, hello, everybody. Uh, Thank you for joining us for Creative Healing for Youth in Pain, or CHIPS webinar, Pain in Pediatric Rheumatic Conditions with Dr. Megan Curran. For those of you who are new to the community, CHIP is an online nonprofit organization that empowers youth living with chronic pain to heal by altering the brain's pain circuits through exposure to creative healing experiences, educational resources, and peer support. My name is Rebecca Cherry. I'm a pediatric gastroenterologist in the Philadelphia area who sees a lot of patients with a variety of chronic pain conditions, not only in the abdomen, but mostly in the abdomen. And I'd like to introduce our speaker. So Dr. Megan Curran is an associate professor of pediatrics at the University of Colorado School of Medicine and a pediatric rheumatologist at Children's Hospital Colorado. And in addition to being an expert in clinical pediatric rheumatology, taking care of patients, including many with juvenile myositis and systemic sclerosis, she's also an expert in teaching rheumatology to medical trainees. She directs the Pediatric Rheumatology Fellowship Training Program in Colorado. And so we're really privileged to be able to learn from her today. So I think we are ready to begin. Dr. Curran, I will hand it over to you to start us off by talking about what is rheumatology?
What is rheumatology? So, rheumatology is something that many people don't have have never heard of, and B, if they have heard of it, they don't really understand or know what a rheumatologist does, even other doctors sometimes. So, don't feel bad if you don't know what we do. So, what we take care of are inflammatory conditions that affect the musculoskeletal system and or the entire body. So all the systems of the body. And what I love about being a rheumatologist is I just don't focus on one thing, one part of the body. I get to think of the body as a whole, how everything interconnects, and really importantly, the patient's personality, the psychology behind what's going on. I love to get to know my patients as people, who they are outside of the doctor's office. Rheumatologists, the things that we take care of, the conditions that are the most frequent rheumatic diseases in kids. Number one is juvenile arthritis. So the longer term is juvenile idiopathic arthritis. We use a lot of big words in medicine. I'm going to try to make sure I'm using words that are more understandable. But idiopathic means the cause is unknown. And I think that's a terrible name because we actually do understand a lot of the cause of it. But you all might know of it as JIA. And it used to be called JRA, juvenile rheumatoid arthritis, but that's our most common condition that we take care of. And then lupus, systemic lupus erythematosus, which is also abbreviated SLE. Most people know it as lupus. So people can have, it's an autoimmune condition that affects all the systems of the body, but some people with lupus have it affect only their skin. And then we take care of a condition called dermatomyositis. So derm means skin, like dermatology. Myos means muscle. So it's a condition where patients have inflammation of their skin and their muscles. All kinds of other things that we see in kids. And many of the conditions we take care of, patients have pain. That's one of their initial presenting problems, why they wouldn't go to a doctor for the first time, because something hurts. And that pain can become chronic over time, especially if me, are not doing a good enough job in understanding the underlying reasons behind the pain and how to treat them effectively.
Okay. So that leads me to a couple of questions.
Mhm.
One of them is, what do you think is the biggest misperception of rheumatology? What do people think you treat that you don't actually treat?
Yeah. So technically, I guess I'll say we'll start that way. Um, we treat inflammatory conditions. So this means that we come after a patient's, say, joint pain. If a patient has a swollen joint, it could be because there's an infection. It could be because there's something wrong with the bone underneath the joint. There's lots of things that it could be. And we have to think about those things first. And if we rule those out, then what we're left with is inflammation. So, inflammation is basically what happens in the immune system when it turns. So, this can be confusing too, because the immune system, when it's doing what it's supposed to do, is it turns when there is a foreign invader, like a germ. And so inflammation is a good thing in that sense. So what happens is, so that swollen joint, say that is a bunch of bacteria in there. The immune system, which is like white blood cells and antibodies and chemicals, they come into that area. They recognize that something's wrong. They go in there and they fight and they kill the bacteria
Like they're supposed to.
like they're supposed to,
Mhm.
exactly. Um, and it causes swelling because all of those cells need to come in, so more blood flow goes to that area. So inflammation, there's 5 features of inflammation. So we learned this in medical school. Actually, I have a really cute slide if people are interested. I can share my screen.
Yeah,
Um,
yeah, it would be great.
let's do that. So this is a drawing to help us remember what we call the 5 cardinal signs or the 5 signs of inflammation. So heat, redness, swelling, pain, and loss of function. And these were described, I don't know, way back in like Roman times. And these are the like Roman or Greek words for it. That's why it looks like columns. So inflammation can be a good thing if there's like an infection, but inflammation can also be turned on inappropriately, and that's where a rheumatologist comes in. So we don't take care of inflammatory problems when they are caused by infections, cancers, things like that. We take care of it when the immune system is inappropriately activated, causing
Yeah.
pain and swelling in various systems of the body.
And I've heard both in my own experience and what I've heard from patients, sometimes it can be hard to figure out when a condition is a is most appropriately treated by someone like you, a
Yes.
rheumatologist, versus another specialty. And
Yeah.
in particular, there are certain like lab tests that will sometimes get people directed in towards you, like an
Mhm.
ANA test or other kinds of tests like that. Could you talk a little bit about what those are? Because because many of the patients who or many of the people who have chronic pain may have been tested for some of those things.
Definitely. So when I was beginning the answer to the last question, I said technically, kind of like ideally, but what happens ideally and what happens in the real world are different. Um, Ideally, a rheumatologist would come in after some of the workup for those other things has been done because those are in things like infections or cancers or non-cancerous problems with bones, for example. Those are taken care of completely differently, and you don't want to come to us first. I know enough now that if those haven't been thought about in enough detail, I'll do that first. But we don't like people to have to wait to come see a rheumatologist when the problem is not a rheumatology issue. And in a lot of parts of the country, there's a long wait to see a pediatric rheumatologist. Um, but in the real world, when people, kids, adolescents come to a primary care doctor with pain in their body and sometimes like fatigue, other symptoms like rashes, fevers, that combination, maybe two of those things, will make a pediatrician or a general practice doctor think about, oh, could this be a rheumatology problem? And I'm always happy when they think about it, because the most important thing is that we see patients early in the course of what's going on. So it's like this fine balance that has to be struck. But when people learn, doctors or physician assistants, nurse practitioners, what they learn in school is if you think that a patient might have a rheumatology problem, then you order these two tests. And it's almost like a knee-jerk reaction. So the two tests are anti-nuclear antibodies, or ANA, and another one is rheumatoid factor, RF. So we get referrals for patients for whom those tests have been sent and they're positive. And my job is to figure out, is it significant related to what's going on with the patient?
So is it possible to have a positive test and not have a rheumatology problem?
I would say most of the time when patients are referred to us with those tests being positive, the answer actually is, even though the test is positive, you don't have a rheumatology problem, which is great. But I always keep an open mind, because rheumatic diseases are very complicated and they're mysterious and they don't follow rules. They're very notorious in not being good rule followers. So I don't want to dismiss patients, and I would hate to miss a problem. So I always think about it from a global, kind of a big wide perspective. Um, but it is quite possible, especially with an ANA test, to have a positive ANA and have it not be an underlying problem.
Okay.
I can explain a little more about what an ANA is, if that would be helpful.
Sure. And then I'm going to ask you a question that I already have in mind about what families can do to get information while they're waiting to see somebody like you if they have a positive test like that. So yeah, so
Because,
what does it mean? And then
yeah,
how can people find more information?
totally. Because nowadays, patients get their results the minute they come in from the lab. They get it just as quickly as the doctor does. And they need to wait some time for their provider to explain what that answer means. And a lot of times, primary care providers don't really know what it means. And so poor families are waiting and worried. And what makes me the most sad is when I walk into a room and I see a family that is just so nervous and they're sitting on the edge of their chairs because this test is positive, the ANA, and they think my kid has lupus. And by the end of the visit, I'm very confident they don't have lupus, and I just feel terrible that they've been under that misconception the whole time. But anti-nuclear antibodies. So we were talking about the immune system. So the immune system consists of cells, like white blood cells, and then products, or things that white blood cells make. So white blood cells make antibodies against proteins that are foreign generally. So most people know, especially after the COVID pandemic, that you get the virus, or you get an immunization, and your body learns to make antibodies that then recognize that virus or parts of that virus, and they come in and they find it in the body and they grab onto it. So what's normal is to make antibodies against foreign invaders, germs. Um, but the immune system can get confused, and it can make antibodies against parts of our own human cells.
Hmm.
And our immune system is doing that all the time, but it's really smart and it generally knows how to get rid of those antibodies. Um, and it happens a lot, for example, when we're sick, when we have an infection, because cells will go into the infection and they'll kill off the infection, and then the cells will die. And when the cells die, the immune system, that's normal. That's normal. It's not a bad thing. The immune system might recognize, oh, hey, what is this thing that's a part of a cell, and make an antibody against it. So
Meaning the cell
anti
that from the person's own body.
from the person's own body.
Mhm.
Exactly. So anti-nuclear antibodies, for people who've taken biology class, I think even in elementary school, we learn about cells and the different parts of the cell, like the nucleus where the DNA lives and your genes live. So anti-nuclear antibodies are against parts of things that are in the nucleus of a cell.
Okay.
So the important thing about ANAs is that 99 point something percent of people who have the condition lupus will have a positive ANA test. But many people with other conditions and even people who are healthy will also have a positive ANA test. And so we have to think about the significance in terms of what else is going on with the patient.
Okay. Yeah. So that sounds like a pretty big but, because it sounds like a positive ANA could just mean that you've been infected by a virus at some point.
Yeah. Yep. And so if someone goes to see their doctor and they have joint pain after having been sick with like a virus, um, that could just be that it's not an autoimmune long-term chronic problem like juvenile arthritis. It could just be part of having an illness, and that ANA might be positive because the person was sick. So I always try to remember to ask, do you remember when you had this blood work done? Were you sick or had you been sick? Because that might be the reason that the ANA was
Mm.
positive.
Okay.
But the job of a pediatrician, Dr. Cherry and I were talking before the webinar started that we both really like mystery novels, and rheumatologists are detectives. We like to solve problems, solve mysteries. And so what we have to gather is clues. And what I thought I might talk about a little bit today that would be helpful for the people listening to the webinar are the questions that you might be asked by a provider when you have pain in your musculoskeletal system, meaning joints, muscles, bones, and how we can distinguish what type of pain, where that's coming from. Because
Yeah.
some of that is could be some types of pain are from an autoimmune condition or an inflammatory condition, and other types of pain are from other things like the structures in the body or mechanics, like how we move. So that's one bucket. I call them buckets. That's one bucket. And then another bucket is inflammatory pain, which sometimes is infection or other things, and sometimes it's rheumatology, inappropriate turning on of the immune system. And then the third bucket is amplified pain, where the issue is in the nerves that are signaling to the brain that there's pain, and that's what's broken. That system is acting inappropriately.
And is it possible to be in more than one bucket at the same time?
It is. And that's a really good question. And certainly having a mixed picture is sometimes, gosh, I wonder what percentage of my patients are actually, once I figure out what bucket they're in, there's probably a good percentage of people who have pain coming from more than one reason.
Mm.
And I would imagine the kids and adolescents who are coming to the CHIP website and taking advantage of all of the resources available, they might have pain coming from more than one of those buckets.
We do have a question from the chat.
Mhm.
I don't know if this is the right time for it, but it's about fibromyalgia. What is fibromyalgia?
Oh, yes. And that's good because I didn't get to that when we were talking about what a rheumatologist takes care of. So fibromyalgia is that amplified pain bucket. It is where nerves are signaling that your body hurts. And the pain is real. It is there. You're feeling it, but there is not an underlying inflammatory problem or structural problem. Or there is, there was, and those pain pathways have been turned on. And even if the underlying issue has gone away, the nerves are still signaling. So it's amplified pain. And rheumatologists, when I in a world where if we had enough caretakers for patients who have amplified pain, a rheumatologist might not be very involved other than diagnosing what they think is going on, because the care for fibromyalgia, amplified pain, isn't my specialty necessarily, because the drugs I use, that I prescribe for my patients with lupus or arthritis, are medicines that reduce inflammation, suppress the immune system, but those wouldn't be helpful for someone with amplified pain. So many rheumatologists, once they figure out what's going on and are confident that there's not an underlying autoimmune problem or inflammatory problem, will then refer patients with fibromyalgia or other types of amplified pain to physical therapy. There are some multidisciplinary pain clinics at pediatric hospitals. Other types of practitioners, people who do biofeedback, hypnosis, that will help much more than anything that I could ever recommend.
Okay. Yeah, and that was actually going to be my next question about how do you treat patients,
Yeah,
especially those with pain?
yeah. So what's really important for a patient and their providers, their doctors, to understand and to think about is, what is the source of the pain? And that's what I'm always really curious about. And that's where the detective part of me comes out, because you need to know where the pain is coming from, why it's there, in order to treat it the right way. So if, let's see, I'm going to think of a good example of, okay, someone who is very flexible in their joints. That happens to be me, for example. Being very flexible in joints can cause joint pain because the muscles and the ligaments, let's see, like I can hyperextend my elbow. Like it goes more than that's straight, it goes beyond straight. That can cause pain in the joint because ligaments that are holding the muscles into the bones get stretched, things get out of alignment. So that becomes a mechanical pain issue.
Uh-huh.
And medicines that I use for patients with inflammatory arthritis or pain in the joints due to inflammation generally don't help.
Okay.
So, yeah, did I answer your question fully?
Uh, I I think so, yes. So basically you want to have the right tool for the right job. And
Yes. Okay. Thank you. Yes. And patients and parents can actually do a lot in thinking about what's going on with the pain in order to be able to explain it to their providers, to help their provider figure out what's going on. And honestly, a lot of the time, a parent or a teen has Googled their symptoms. And I don't tell people don't Google anymore. I say do your thing, because there's a lot of really good information out there, and you might end up figuring out what's going on, or at least you can come to your doctor with better language to use, things to think about, and ways to describe what's going on that's gonna help the provider. And before I forget, I want to go back to fibromyalgia, because I want to give a little more detail to the person who asked that. So fibromyalgia is amplified pain generally it's in the musculoskeletal system, and it's above and below the waist. So arms, neck, back, shoulders, legs, thighs, calves, um, any part of the body can be painful. And fibromyalgia is generally associated with other symptoms outside of the musculoskeletal system, especially the biggest one is non refreshing sleep. problems with sleep. And when patients don't sleep well, when we sleep, that's when our body heals. And when patients don't sleep well, or people in general, their body just feels like crud. And that's a big part of what fuels fibromyalgia.
Mm.
So I wanted to explain that a little further. And many patients with fibromyalgia have pain in other systems, other parts of their bodies too. Like they could have stomach aches and headaches. Their pain can come more when like weather changes, when there's a storm coming, that can affect the pain. There are other environmental things that happen. Stress, for example, for kids with fibromyalgia when they have an exam coming up in school, or if they're fighting with their friends, or if there's drama at school, that can make their amplified pain worse, for example.
Mm.
So pediatric rheumatologists will sometimes avoid using the word fibromyalgia, and instead will say amplified pain, or one abbreviation you might hear is AMPS, amplified musculoskeletal pain, because fibromyalgia kind of has a stigma associated with it, or it can, um, where providers or just the general public might think, oh, people who have fibromyalgia, they're always complaining, they always have pain. And we don't want to think of our patients that way. We don't want to give them a label that is not helpful. Sometimes it's helpful for me to say, use that word, because families have looked it up, or there are people, adults in the family with fibromyalgia. It's actually an adult diagnosis. It was way before we started calling it AMPS in kids. Fibromyalgia was described as a problem in adults. But we don't want our patients with amplified pain to be dragged down by stigma, by people having misperceptions or negative thoughts about what a condition is. It is what it is, and it's an issue with the nerves and how the body is sensing pain, and it's real. Like, I will say that over and over again, because the amount of dismissal, or, oh, this really isn't a medical problem, this is a psychological issue, you must be depressed or anxious, those kind of things, that's not helpful. It is a true pain problem, and there are medical ways to help make it better. People might have heard of medicines that are prescribed for fibromyalgia. There are some medications like gabapentin, or pregabalin, which is Lyrica, that change the ways that nerves signal each other to turn on pain signals. Those are used frequently in adults. None of them are approved in kids. And my experience with kids with fibromyalgia is medicines like that are only effective for a small group of patients. But we don't know. We can't tell who it might help. So there are some pediatric rheumatologists who will follow and manage patients with fibromyalgia and prescribe medicines like that, but always within the context of a bigger care team. And then there are other pediatric rheumatologists who will refer patients with fibromyalgia onto a multidisciplinary pain clinic, because we have a long waiting list for patients with inflammatory conditions like juvenile arthritis, which is where most of our specialization lies.
Okay. All right. So thank you. Another question, which again might have more to do with musculoskeletal issues, but you'll let me know. Um, Another question from the chat. Why do patients have increased pain after they've been sedentary for chronic pain?
Yes. So that's a great question. I think now might be the time to go to this slide, because I hope it's going to be big enough.
And then there is also a question, can a patient have both juvenile arthritis and fibromyalgia?
Yes, right? And that's very confusing. So if the inflammatory part of what's going on with a patient isn't well controlled, that can lead to fibromyalgia. And once I know that a patient's arthritis, juvenile arthritis, is under good control, there's some ways that we can figure it out together. And if the patient still has pain, that's where we start thinking that there's those nerve fibers that were appropriately signaling pain when the joint was inflamed, just they didn't heal. They didn't go back down to normal. It's like the volume got turned up on those nerves. And ideally, the volume gets back down when the underlying inflammation is better. But if it doesn't, then there's amplified pain on top of having a rheumatic disease. And that can be really confusing. So I realize this is small. There we go. Okay, actually, that might be okay for you to read.
That's not bad.
So please take a picture of this, because this, I think, is where I'm talking about questions you might be asked about your pain. And this is like a compare and contrast table in how we figure out whether a patient's pain is inflammatory, mechanical, or amplified. And like I said, things don't always follow rules, but these are general truths, I would say. So the question in the chat is, why do people have worse pain after being sedentary? So that can be for a few reasons. It's very common in people with inflammatory pain, like juvenile arthritis, where joints are swollen, and the white blood cells are in the joints or around the joints, in the bones, the tendons, the ligaments, causing swelling and pain, that when you, for example, when you sleep, when you're laying still in bed all day or all night, in the morning you wake up and you feel stiff. So all of the inflammatory chemicals that are floating around in those swollen joints cause the joint fluid to get more like jello. And so patients feel stiff when they first wake up. And it takes a while to get going, but movement makes it better. We say motion is lotion. So that's one thing. So when pain is inflammatory, it tends to be worse after inactivity. Patients with amplified pain can also sometimes, and even patients with mechanical pain can sometimes have pain after inactivity, because things will stiffen up, part structures will stiffen up in the body. The other thing that can happen is, say someone has amplified pain and they're not using their body much because it hurts, right? That's self-protection. If my leg hurts, I'm not going to walk on it, or I will put less weight on parts of the body that are painful. What happens then is that muscles get weaker, the ligaments and tendons that hold the muscles and the bones together then don't have as much support. And so then there's a lot of like rubbing together of things get out of alignment, and that can cause pain. So that's another reason that after inactivity, that pain can feel worse.
Is movement ever a bad thing?
Almost never, I would say, in my world. Now, if someone has a fracture or a sprain, then they need to rest, and that body part needs to heal. But movement in general for patients with inflammatory conditions like juvenile arthritis, lupus, dermatomyositis, movement will not turn on the immune system and make the inflammation worse. Movement tends to make things better. And it's hard. It's hard for me to tell a patient, I know you're hurting, but movement is actually going to be helpful for you, definitely in the long run, but also in the short run too. So we have to think about ways that we can keep you moving, that are not going to make things that make you hurt more. Because when you don't move, again, like you get these weak muscles, your joints get looser, and it just perpetuates the problem. Just things keep going on and on. So it's super, super rare for a rheumatologist to actually put a brace on a joint that's swollen or inflamed. We may restrict certain activities, but we want our patients to be active. And importantly, we want them to be kids and teenagers and just live a life and do all the things that kids do. Kids love to run and jump and play. And when those are not going to cause harm, we want them to be out there doing all of those things.
And how about foods? Are there any particular foods that seem to make things better or worse in terms of inflammation?
Yeah, that is a really good question. And I wish that science knew more about foods. There is a huge connection between our intestines, our gastrointestinal system, the gut, and the immune system and the brain. There are certain types of diet that are considered to be anti-inflammatory that might be helpful, especially when the underlying issue is inflammatory. What I refer people to, there's a lot of information on the internet that is inaccurate, or it is because the person sharing the information is selling a supplement that they want to sell people. If there was one thing that people could change in their diet, or even a list of 10 things that would make them all better, like I'd be out of business. We'd all be out of business because we would all know what it is to eat to reduce inflammation and to help pain. And we're just not there yet. So what I refer people to is a website. I'll probably want to look it up to get you the right, direct you exactly where, but it's Dr. Andrew Weil, Weil. He's actually an adult rheumatologist, and he is one of the gurus of integrative medicine, and has a diet plan that is very similar to the Mediterranean diet people might have heard. So less red meat, more fruits and vegetables, antioxidants. He's really big on mushrooms, which is a problem for me because I don't like mushrooms. But there's actually some pretty good science behind that anti-inflammatory diet and the Mediterranean diet being helpful in reducing inflammation. You'll also find sources that say dairy is inflammatory. Nightshade vegetables are inflammatory. Those are things like tomatoes and I think eggplants.
Eggplant.
Yep.
I think peppers, maybe?
You can answer this better than me, Dr.
Yes.
Cherry. Yep, peppers. Yep. Gluten. And I think that's a very, very slippery slope. And sugar, unrefined sugar, processed foods. Of course, most people know what the healthy diet we should all be following is more fruits and vegetables and not so much dessert and unrefined sugars. But sometimes I'll have families come and say, I really want to manage my child's arthritis in the most natural way possible. So we read that we need to restrict dairy, no, take away gluten, dairy, sugar. And I'm like, what's left? And like, take away fun as well. Like we get a lot of pleasure out of foods, and I don't want to restrict foods that bring people joy, and I don't want them to restrict their diet to the point where they're not getting the right nutrients.
Wow.
I will say if a patient has celiac disease, like that is a definite restriction in diet. And some patients will have the testing for celiac disease that does not show the antibodies or the changes in the intestines related to celiac disease, but they feel better when they remove gluten from their diet. And I'm almost curious what you think, Dr. Cherry, because I'm not going to argue with someone who says I feel much better when I don't have gluten, and that's whatever feels right to you is good, but I don't want patients to restrict things that are unnecessary, if that makes sense.
And from my GI standpoint, I would agree with that. Um, I feel like gluten is such a huge topic. It could be a topic of its own whole webinar,
Oh,
but
yeah.
or even maybe I should say more broadly, wheat, because gluten isn't the only part of wheat that can cause symptoms. So sometimes when people say they feel better on a gluten-free diet, it's not so much the gluten as something else that's in the wheat.
So that's such a good point. That is a really good point. I don't think about it that way, and I should. Thank you.
Yeah,
Yeah.
absolutely. Yeah. Um, you mentioned you mentioned families wanting to have their kids um, health managed as naturally as possible.
Mhm.
And I know that a lot of families, in addition to seeing um, MDs at, at medical centers, also see a lot of other kinds of health professionals like um, functional medicine experts
Mhm.
or naturopaths.
Mhm.
And I'm wondering what you think. I don't know if there's a way to say it briefly, but what do you think about those kinds of supplements or testing that's recommended?
Yeah, this is a really important question. I'm formulating my answer. Let me answer from my personal perspective, and then I may try to give you an answer that I've seen other providers give to families. So, what we learn in medical school or training for any kind of health profession is first, do no harm. Um, but that often comes down to is weighing risks and benefits, or always wanting to be on the side of benefit for the patient. So, certain medications have side effects, for example, but if the benefit caused by that medication is so much better than the problems related to the side effects, then I'll recommend that medication, for example. So, for functional medicine, integrative medicine, Eastern medicine like Chinese natural medicine or herbal medicine, acupuncture, things like that. I personally am very open to patients exploring other things, other types of treatments, because I really think that I'm not Western medicine or how I was trained in getting a medical degree in the United States doesn't have all the answers. I think the answers are very broad, and I encourage people to seek some other opinions, um, because really I find that they will take a little from me and a little from other places, and they'll put it in the pot and they will have their soup that works for them. Balancing out risks and benefits or pros and cons, it can be expensive. And I don't want people to be taken advantage of financially. So that's one thing that's really important. Um, and I do think that there really is an important role in using the scientific method to understand whether a diet or a medication, some type of intervention is actually helpful. So um, I really like it when there is scientific evidence or a study that was um, put together in an accurate scientific way. That's what I'm looking for to really make me feel comfortable recommending things to people. And there actually is some good science behind fish oils or omega-3 fatty acids as being anti-inflammatory. Um, I don't just recommend fish oil. I think in itself, it's not going to solve all the problems of someone who has an inflammatory or an autoimmune condition, but it can be very, very helpful. Um, Turmeric is another herb, is an herb that has really good anti-inflammatory properties and a lot of good science behind it. Of course, the studies are almost always in adult patients, and children are not just little adults.
Right.
Um, it's really hard to do scientific studies in children for various reasons that are to protect the well-being of children. But we can extrapolate some things, and the more studies there are on certain diets, certain supplements that are well designed, accurately designed, that show a good benefit, that's where I feel more comfortable recommending things like that.
Okay. And there's another question from the audience along the lines of this discussion of supplements. What about pro and prebiotics and digestive enzymes?
Oh gosh, I might throw
Um,
that one back to you. um, so my understanding of prebiotics and probiotics are that these are bacteria that I hope that most people here know that we actually, as humans, we live with friendly bacteria throughout our body, especially within our gut, and that those bacteria can kind of get out of balance. For example, if someone takes antibiotics, I think that's kind of probably a good example to start with. So say you have strep throat and you take antibiotics to kill the strep bacteria in your throat. That's important because if you don't treat with antibiotics, then you can go on to have problems over time. But one of the side effects, one of the cons, is that it might kill off some of the happy, good bacteria in the gut. And so probiotics are putting those healthy, happy bacteria back in the gut. Do you agree with that answer as a gastroenterologist?
um, Pretty much. You know, pre and probiotics, I agree, it is such a complex topic, and there is so little that we can say that's definitive.
Yeah.
Um, but yes, the thing, something to know about probiotics, though, is that even if they're good, healthy bacteria, they generally don't permanently recolonize the intestine. They're present for as long as you're taking the supplement, and then they tend to disperse after that.
So that's a great point. So it takes more than just taking a prebiotic or probiotic to get things back into balance in the gut, is what you're
Yeah,
saying.
yeah. I would say diet is probably the more important factor in um, most of the time in altering gut bacteria.
In bringing that kind of back into balance.
Yeah.
I think that's such a good point. And I think I already said, like, I don't want my patients to be taken advantage of by buying supplements that are expensive and really don't have proven benefit. And that's where it takes a village to think about what's best for a patient. It may be that a supplement really just isn't the answer, but there's lots of other things that are natural that may be a good part of the answer for someone who's having pain or inflammation.
Yeah. And in fact, something that I like to do if a patient is about to start, let's say, a probiotic, is I ask them to reevaluate in a few weeks whether or not it's actually made a difference, because it may not have, the same way that a prescription may not have made a difference. And
That is so true.
it may not make sense to continue it. Or it might make sense, it might make great sense to continue it.
It's so true. And this is where I like to remind myself and talk to families about changing one thing at a time and being your own scientist and observing your body and how you feel when a change is made, like when a new medicine is started or when you add something to a diet or remove something from a diet, because when you do a lot of things at once, then it's really hard to know what made the difference. Sometimes as a doctor, we have to do what I call throwing the spaghetti at the wall, or doing a lot of things at once because a patient really is in a lot of distress. And I don't care what works, I just want them to feel better and we'll sort it out later. But in general, making one change at a time so we can have an informed decision and helping families to think of what's going on in their kid's body or their behavior, so they can come back and report, and we can work together to figure out if something's helpful or not.
Um, little bit on a tangent from that discussion of supplements. What about other sorts of devices or gadgets that people use, nerve stimulators, let's say,
Yeah.
or bands of some kind?
Yeah. This is a really exciting time to be in the healthcare field, I think, because we are learning so much about the body, and this is like really like a brand new thing. Like vagal nerve stimulators have been used for patients with seizures, and now they're being tested in patients with other conditions. And there was a really good study done in patients with rheumatoid arthritis that showed that vagal nerve stimulation turned down the signals of inflammation in the immune system. And that's like mind blowing. That is super exciting. How that works, there's a small understanding, but not a big understanding. And is it safe? Could it cause other problems? Like, these are all things that we have to think about. So I don't think it'll be a magic bullet, but I think, especially as time goes on, pediatrics, we're always behind. Just again, that issue with testing devices or medications in kids, it's just harder to do and it takes a longer time. So it'll probably be a while before nerve stimulating treatments are recommended for inflammatory diseases in kids. But the science is starting to look like there's some really positive signals there.
Mhm. The
Um,
this oh
I'm just thinking if there are other devices that I could talk about. TENS units. So transcutaneous electro nerve stimulation. Am I right? Something like
I
that.
believe so, yes.
Yep. So TENS units are fascinating. So TENS units, there you have two little pads that are attached to a device that puts out an electrical pulse. And those can actually be quite effective in patients who have amplified pain or structural pain, because the kind of the zaps, the little electrical signals, are interfering with the nerve signaling that's inappropriate. So that can actually help to bring about a reduction in pain. One of my favorite things, it's actually on my ID badge right here, is, I don't know if y'all can see. I think it's upside down. Fuzzy helps. I don't know if anyone listening has ever had a blood draw and used a device similar to or the Buzzy Bee. So the Buzzy is a little plastic bee that when you turn it on, it vibrates just like that. Doesn't sting you, but it just vibrates. And for patients who need to get a blood drawn or have a shot, like some of the medicines I prescribe are injections. If you put the buzzy or really anything that vibrates above where you're doing the shot or the blood draw, it confuses the nerves that are going from the painful site that are heading their way up to the brain. And the body focuses more on that vibration and it takes away the pain. Like, that's amazing. It has helped so many patients who were very, very afraid of blood draws. Like, that is a huge intervention that helps.
That sounds very practical and like, can people just get those on the internet?
Yeah, you can, and you don't even have to buy that thing. It's just the vibration that makes a difference. So if you have like an electric toothbrush that vibrates, you can put that above the site of doing an injection or a blood draw. There's a lot of creative things online. If you have a Theragun, like a massage gun, that works too. So just think about it as interrupting that signaling that's coming from the painful site. It's pretty cool.
Well, I think we are just about at the end of our hour. Are there any things that we haven't talked about that you think would be especially useful for our audience? Oh, and there is one more question, um, uh, which is about pain in one part of the body blocking pain in another part.
So I wonder if what the person is asking about is, certainly people can have pain in two places. Say you've got arthritis in one knee and you sprain your ankle on the other side. I can I can see how a new ankle sprain might actually distract your pain sensing from the pain in the arthritic pain that's going on. So I think what the person is asking is like, is that a thing? Does that happen? And I think it could. I think a lot of it is distraction too. Like, you're gonna pay more attention, your brain is gonna pay more attention to the thing, the stronger pain or the newer pain. And then you might be distracted away from the pain that is in another place. So I think that's probably what somebody is asking there. I'm not going to go and tell you to sprain your ankle if you have arthritis. That's not going to help. But it does make sense that especially that distraction is a huge part of pain. Well, that's how the buzzy works in a way. It does disrupt that signaling, but it also distracts you. So you're thinking more about the buzzy than you are the blood draw, for example. I can't underestimate the power of our minds. So, and that's a nuance, because if talk therapy helps someone who has amplified musculoskeletal pain or chronic pain or inflammatory pain, it doesn't mean that it's all in their head, right? The pain is real, but ways we think about and intervene in pain, a lot of it can be changed in the way that we think. It's really important to understand that nuance, because if a provider recommends talk therapy, seeing a psychologist or a social worker to talk about what's going on with you, that does not mean, at least for me, that I'm saying that the pain is all in your head and that's what's going to fix it. It's multifactorial, but even me personally, I have done some amazing therapy that has taught me how to think about things differently in my life, that has really changed how I feel in my body.
It's really amazing. I like to think of it sometimes as bandwidth.
Mm,
When it comes to the multiple different kinds of pain or the distraction from pain, right? If you've got limited bandwidth, if you're paying attention to one thing, you just can't pay attention to, you've got less attention to pay somewhere else.
yeah, it's very true. And that's where I think working together with practitioners or providers whose specialty or interventions are different than mine in Western medicine, that's where I like to see working together and finding that soup that's right for every patient.
There's no single recipe.
There is not a one soup fits all. Definitely. Yes. And if it's mushroom soup, I'm not eating it. No, no mushroom soup for me.
Regardless of what Dr. Weil says.
Right. Sorry.
Okay, I've got one more question, which I think might be a quick one, and then we'll wrap it up. I do have some closing announcements, but what about infrared light therapy?
So that's a good question. And this is something that I have been meaning to look up and try to understand better. I think the quick research I've done on it is that it doesn't really make sense to me how it would work. So it's not something I recommend for patients or families. But again, I'll say, like, if someone is doing it and it's helping them, I'm not going to dismiss it. But I'm also not going to tell people go buy an expensive device, things like that. Sorry, I don't want to. There may be science out there that I just haven't read yet, but that one I have a harder time understanding how infrared light, because I've seen devices where like you put your arm in and expose it to infrared. I'm not quite getting the connection there. And I will say that there are certain rheumatologic conditions where light exposure actually can make their condition worse, their inflammation worse. It's not infrared, it's more UV light. But that's again where the balance comes between doing benefit and doing harm, or pros and cons, things like that. So that's probably the best answer I can give right now.
Okay, so maybe something to add to the soup.
We'll add this. I always call it the parking lot. I have a parking lot every time I give a talk. I'm like, ooh, something to think about. I'm going to put that in the parking lot. I'm going to look it up later.
Okay, excellent. All right. Well, thank you so much, Dr. Curran. It's been a lot of useful information and interesting information. And thank you all for your time and your attention.
Thanks for having me.